So, I almost don't even want to show this case because it's another case of, have you ever experienced the following? We just experienced it. 54-year-old guy with sudden onset of shortness of breath and left pleuritic chest pain, who's borderline blood pressure, tachycardic and low sats, and this kind of clot, large clot volume of thrombus. And by the way, I'll just say that, there's never been a study that really showed that the volume of thrombus in the pulmonary arteries actually defines or is a risk stratification for increased for poor outcome. Interestingly, troponin 1.5, BNP elevated, echo shows RV dysfunction, and then there's the confusion in PE decision making. What do you do? Will removal or lysis of the thrombus make a difference in his clinical course and his outcome? And I don't know that we can actually say that. And you just heard exactly that's a scenario. We don't really know. So you have the option of aggressive versus conservative therapy. There's a lot of options available. Yet there's a paucity of high-level data that actually shows what's effective and what's more effective and less effective. Evidence base is incomplete. Markers of risk are non-definitive. We are often in a data-free or data poor zone, and confusion reigns in this whole specialty. I will just tell you that this is so different than coronary artery disease or stroke, where we really know the other two leading cardiovascular causes of morbidity and mortality, where we really kind of have a pretty good sense based on evidence what to do. So PE is a challenging disease to manage. The evidence base is incomplete. There's no standard approach, especially for these high and intermediate risk patients. I mean, the low risk ones, you anticoagulate, and you can argue about what the different anticoagulants are, but at least it's pretty standard. But when they get up to the category where you decide, yes, this is a patient who probably will benefit from advanced therapy, there's no sort of consensus. And the strategies that are placed that years ago were all over the map. They're still over the map, but there may be a little less variation. And it varied by medical service, where the patient was. There was no standard algorithm or consistency in decision-making, no single team or specialty that was taking care of this. And there's no centralized location for care. These patients were cared for all over the hospital and in the emergency department. And it depended upon who saw them as to what therapy they would get. And there was no systematic evaluation of the results. So, the result is, and this is around the world, less than 5% of PE receive advanced therapy, even if they have really clear-cut indications. Here you have an advanced group of people talking about these cases. Got Aki and Jim and all of us here who deal in this space. But I will tell you that in community hospitals or places where they're not used to dealing with PE, their default is, well, I don't want to cause any harm. I'll just put them on anticoagulation, even if they're really, really high-risk patients. And that's why the mortality is high. So people fail to recognize the benefit. You heard Greg talk about the risk of bleeding. So that causes a paralysis in decision-making. Even at our institutions, but certainly in other institutions which don't deal with this on a regular basis. This was my aha moment. That should be AHA. This is my aha moment, which is a patient that about 6 or 7 years ago, young woman, attorney who collapsed in her kitchen. She was 25 weeks pregnant, 34 years old, and really came so close to dying. She actually ended up having a thrombectomy. Open surgical thrombectomy, could not get off pump, needed ECMO at the time, was transferred to our institution. She had lost 120 units of transfusion during her stay at MGH, but she survived only through the input of a multidisciplinary, coordinated, collaborating team. Otherwise, she would have died, and there's no question about that. And this is her a year later, celebrating her 25-week preemie that was now a year old and doing well. So in the wake of that, we actually created a multidisciplinary effort. We said, we got to do something. We sat around a table and said, what's happening in PE at this institution? We need to do a better job. We created this what we called the PERT, the Pulmonary Embolism Response Team. And the mission was to advance the diagnosis and treatment and outcomes, and to improve outcomes using this collaborative approach, and to develop a rapid response in a multidisciplinary environment. That's different than acute MI, where you get called for STEMI, it's only the cardiologist it's called. Stroke, it's the stroke team that gets called. This is multiple specialties: pulmonary critical care, ED, hematology, cardiology, and radiology, and so on. And we present the full range of options to consider them, and then by consensus, we make a decision about how to treat the patient. And the objectives of our PERT were to respond expeditiously, to leverage the input of the multidisciplinary team of experts, to provide that best therapeutic option, to coordinate the care and develop protocols ultimately that would offer the full range of treatments and collect data so that we could fulfill this unmet need and start to close that evidence gap and row our oars in the same direction and change the paradigm from this crazy paradigm where PE is identified and all the calls go out different ways depending upon who happens to be around and who happens to be on service and who you know, to this very coordinated one call brings together the PERT team approach. And it has worked unbelievably well. This is the collaboration of multiple specialties, not just one, and that is like herding cats a little bit, but I would say it's a coalition of the willing. It's people who want to participate. They'll get on calls in the middle of the night and go to meetings in the middle of the night without getting paid for it because they are interested in the benefits of multidisciplinary collaborative care to improve patient outcomes. We developed a little algorithm here, a flow map, which we use, if it's a low-risk PE, we don't call a go-to-meeting, but if there's a submassive or intermediate risk, high-risk PE, if there's any question about what to do on this patient, we call a go-to-meeting electronically, and it's usually very quick. This is the posters that we hung up around our institution that alert people as to what to do. I can tell you that the first weekend after we put these posters up, I was on call and we got about 6 or 7 calls. It was like, oh my gosh, where are these people? They've been in the woodwork and they came out of the woodwork. And we provided an opportunity. It speaks to the unmet need that even our colleagues around our hospitals feel because they don't know what to do with PE and they don't know the best treatment. So we have this go-to-meeting, and we actually look at the data that you've seen here that a colleague showed in those case presentations, and we have a discussion. It's usually very active and vibrant, I will tell you. We don't always agree, but we do come to consensus at the end. And sometimes the consensus is, okay, we're not sure that there's any value to do anything, but let's watch the patient for the next few hours. So it's not necessarily a static, a one-time thing. It's a dynamic process. So we've gotten a lot of kudos and a lot of benefits for this, not the least of which, by the way, is educating trainees. And it's, one of the most proud things I can say is that people like Jay Geary, who are, now like leading this effort nationally, trained under this PERT module and has really increased the awareness around the world. We published some papers about this early on, and we got this, again, speaking to the need, we got this deluge of calls from friends around the country saying, what are you guys doing there? That sounds really interesting. And at that point, the light went off in my head again that this is an opportunity, and I said this before, if we can coalesce the data from all these people and all these centers, wow, we can really make a major impact on this illness. So we set up a consortium, and I mentioned it earlier. There are bylaws to it, and it basically just requires every PERT at different institutions looks a little different, and that's okay. It's a coalition of the willing. It's an open tent. Basically, we want to be inclusive of whatever your PERT looks like. It just does have to have more than 1 or 2 disciplines involved, and you have to be able to access the various range of therapeutic options. We now have a large group of people in this thing, and it's all over the country. Actually, more on the East Coast than the West, but we're now starting to really expand. And we've done a lot of activities. I'll just, there are lots of educational things going on, lots of publications, and a lot of activity. You heard the thing that Rob is coordinating, the database, which is really spectacular, which I'll show you again here. But just to summarize, Mike Jaff said it well, I think, when he said the PERT Consortium now is at the center of the PE universe. It's the most important opportunity to improve PE care and outcomes for PE to date. So how do you set this up? When you're setting up a PERT at your place, I showed you what we did, and maybe that's a little bit of a template, but it like I said, it can be looking different at every institution. Identify the people who are interested in collaborating, establish guidelines for activation and clinical care. Not every PE needs to activate a PERT. But certainly the ones that are more critical, yes, I think that everybody benefits from that. Understand the availability in your institution of the advanced therapies and how to access them. Develop the robust system for outpatient care. I mentioned at the end of that case, outpatient care. We didn't have it, and actually about 2 years into it, Rachel Rozovsky, one of our members, said, I want to set up an outpatient clinic. We need to follow these patients better. Bingo. Like, what were we thinking? Yeah, they need to be seen and they need to be regularly followed because there's all these questions afterwards. What about CTED, CTEPH? What about just the post-PE syndromes? How long do you anticoagulate them? There's so many unanswered questions out there and opportunities to improve this. So we set it up and now it's incredibly robust. You need to embed quality improvement, quality insurance activities into your model, and then of course participate in the national consortium because we actually have a sort of we used to call it the mentorship program. It's now the partner program, PERT partner program, where some of our current members will actually reach out and help you set up your PERT if you want to set one up. So all of you residents, fellows who go out to your institutions around the country, if you want to set up a PERT team, just call. You'll get lots of help and lots of advantages from those that have already done this before. This is not alone. This other team-based approach to medical care that exists out there. It's not novel to have teams. I mean, stroke, trauma, rapid response. I think one of the things that's a little bit different about this is the broad base of specialties that are involved. And constructing your PERT, the sort of principles that I sort of adhere to, the patient's always at the center. Nobody's always right. If somebody leaves those go-to meetings thinking they've won and they've gotten what they want every time, then there's a problem. Then, because multidisciplinary decision-making requires sacrifice and compromise and willingness to listen and respect other people's opinions and creating an environment of trust and collaboration. And that takes time. It does take time. It's not automatic. Getting buy-in from other specialists. If I could be a more effective member of the team if the others would just shut up and go away. But it says, well, Anyway, so I do believe that PERT and the consortium is the future of management. The state of the art of this thing is yet to be defined, but we're in this new era of a heightened awareness and the ability to actually pull people together. And just going to the bottom there, the team-based approach to decision-making is superior to individual practitioners, especially when there's a lack of evidence. And achieving consensus and coordinated care with collaboration will lead to higher patient care. The time is now. Join the consortium. Come to the annual meeting. Thanks, Rob.